the AIOS International Session, and we have very eminent speakers from across the world participating in this. We are starting 10 minutes late, 10, 12 minutes late. Maybe we'll take that grace time. And no, it's 11 a.m. was the start time. So we have Dr. Virinder Agarwal from Jaipur, a very high volume cataract and refractive surgeon, talking to us about life begins at 33 centimeters. Is your PCOL ready?
Thank you, Dr. Ramamurthy, for giving the kind introduction, and I must thank AIOS for giving this opportunity to speak on the topic. I don't have any financial interest in the topic and talk, but I do use this lens a lot, and I prefer this lens is a lens of my choice, giving away that everybody who can afford, I use this lens. I will just take one of your minute for attention. Just take out your mobile and try to read any SMS. You all can do at what distance you are going to read, and that is the reason of my talk. There was a lot of burden things. People used to say that the intermediate distance is the in thing. I think it is not the in thing, particular for the India. The near vision means it has to be less than 40 centimeter, preferably between 30 to 35 centimeters. There are some people, because of the short arm length in India, are requiring even lesser. So the thing is changed, and that is the reason that I was using multifocal lenses since 1996. Initial lenses were having an addition of +4 diopter. My patients were very happy, except the thing they need to keep it close and at a very fixed point. And that fixed point was a big problem. Then the different lenses came from the same company or the other companies, from bringing to 4 diopter 8 to around 3, 3.25, 2.5, and all trials were done. And they were giving better results in sense because they were keeping slightly away, and the thought was given to the patient itself also. They try to keep it at a slightly distance thing. But now, as you see all, that our life has changed from initially from the print to the computers, laptop, or iPads, tabs, and now mobile. But now I think everything has come down to mobile. You don't require most of the time the newspapers, you don't require TV, you don't require desktops, you don't require these iPads. What all you do that you carry with your hand, and that mobile is giving everything to you. We were using the multifocals, trifocals, but they were all having some gap, and that gap was an issue because there are many people who were in habits of keeping it here or there. So you can't choose and decide that which patient will actually require at what distance. And there are times when you may know it, but they wanted more freedom. And that is why we were looking for a lens in which there is a continuous zone or continuous range is available. And luckily now we have a lens which is with the name of Technics Synergy. I don't have any financial interest in that, again I repeat, but I am using this lens a lot, and I feel out of the lenses available today, particularly for the multifocality, this is the lens of choice. There is a word going on for EDOF also, like without rings, but I still feel the without ring lenses are not giving that crisp vision as the lenses with the rings are giving. So the patient, if can be convinced and are ready to bear with the some of the night vision issues, my lens of choice is these kind of lenses. Why continuity is required? I'm going to share my personal experience. Whenever I used to do multifocal lenses, the next day or after some time I used to say that you have to learn how to read. It is a new lens, new optical system. You were having some of the habits. You have to unlearn them and learn how to use it. So the technique was either ask them to hold a paper here and keep it going away, or bring it here, keep it here and bring it near to the eye and find a sweet spot where they can read well. That was working well, but not for everyone. And it was not accepted by everyone that why should I need to change? You should have informed me before that I will require to change in my learning habits, reading habits, but still it was going on. And I was looking for a lens in which it can be done. Another trick, the personal experience I am sharing, I am having 4 lights in all directions. Depending on the requirement, how the patient is going to read, I used to make switch number 1, 2, 3, 4 are my codes. So my number 1 light is behind the patient. So whenever I used to give multifocal lens, I am keeping it off because I am sitting in front, so it gives the disturbance to me. So I keep it off, but whenever somebody comes that I am not very happy, so I say give him newspaper and number 1. So number 1 code goes for the staff to start the number 1 light, and patient starts reading and he is happy. But that is a kind of cheating. The same thing I applied with the synergy lens. Then what happened? They said, and he noticed it. He said, Dr. Saab, you are doing cheating. So now it is challenge to me what to do. So I asked my staff to off. He did it, patient was still happy. Then I become more bold. Then I asked to switch off 2, 3, and only 1 light was left. So I asked him, should I keep it on or should I keep it off? So he said, I am happy. So that gave me a confidence that this lens can actually work in any light. So another issue which was in discussion previously and may come in the now, that different lenses reduces the contrast, they require extra light. So you need a lens which gives you a freedom for holding your gadget or reading material at a distance. The another thing comes that it should require extra light or not extra light. And third thing comes, now the things are changing from a normal light to LED lights. So for these all, this lens is having different features. So there you can see the MTF or this curve in which different lenses for comparison, no negative for any lens. I used all lenses and may use again some of other lenses in the same way. But trifocality, multifocality or continuous range of vision is under discussion, and in my choice, blending the two technology of multifocal and extended range of vision from the Symphony, they have come out with a good lens and with the advantage of chromatic aberration correction. This chromatic aberration correction gives extra focus in the sense of depth as well as blocking the violet light which is usually emitted from the LED lights. They have taken out a lens in which most of the visual phenomena of light conditions are actually removed. So because of this, my happiness with the patient has really increased, and I am really happy and confident to implant them in VIPs. The last talk in the last session, they was commenting that the multifocality for mainly for females and EDOF mainly for males. This was the time when I started almost in 1996 to up to 2005. I was implanting mainly females. No gender bias, no disrespect to them. But because it was a people believing that putting them in females who are not driving. But now it is equal gender, everybody is driving, and not the age. Even the people who are in 70s are also driving. But believe me, the patients, if informed beforehand that you will have rings around the headlights of the vehicle on the road, majority are well tolerant. Not tolerant, well tolerant. They don't complain. I rarely see a patient who comes and tell me, because of this, you go for explantation. Till date, I have not done, and I used more than 1,000 synergy lenses in my individual practice. So my choice is that you should do this. But be a word of caution that you should not implant in everyone. You need to have a dry eye evaluation. You need to have a proper topography, appropriate biometry, and a constant setting. SIA should be done. I have different testimonials. I will not go for it. But I implanted in surgeons. I implanted in the patients who have undergone LASIK if the topography post-surgery is good enough. My take-home message is that you all should first believe that this technology is going to work. Does not have the problems as it is being hyped by colleagues or because of the past lenses. Now the time has come when everybody wants freedom from glasses, and if you treat him, if you give freedom, it will add on your practice. Thank you very much for your kind attention.
Thank you so much, Dr. Virendra, for giving a comprehensive overview of lens which is worldwide used. Next we have the cataract coach himself, Dr. Uday Devgan, who's going to be talking about how pupil size and centration affects trifocal need of IOLs.
And I'll be properly American. I will not be 1 minute over time. Just hit play. Where's my video? Pull up the video and hit play. Video. This side, okay. There it is. Just hit, yeah, it's just one MPEG file.
CataractCoach.com. Effective pupil size for extended depth of focus.
Go for it. I know. Don't worry. The video is actually less than my allotted time. So hit play, please. Make sure it starts.
And monofocal plus
All right,
IOL.
the effective pupil size
We
for
know
EDOF
pupil
and
size is
monofocal plus
important
lenses.
for
We all
depth
know
of field.
A smaller pupil is
And
a
the
much
depth of
wider
field is
depth of
wider
field.
when
This
we
is
have a smaller
simple optics
pupil,
from way
much
back
like a
when
camera
we were all
with a
young.
smaller
And so
aperture
we know
giving
that
us
you can take
that
into
wide
account,
depth of
very
field.
importantly, for
The
patients
larger
who are
pupil is
having
going to give us
cataract
a
surgery,
narrower
you
depth
really
of
need to
field,
know
but of
what
course
is it
lets
here.
in more light
There's
for
no
dim
audio
lighting
in the video. I'm
situations.
doing the audio
You've all
live.
seen patients in your clinic with
So, but
small
this also
pupils
applies
and a
when we use
monofocal
any
lens,
kind
and
of
yet they have no need for
specialized
glasses
EDOF
near or far.
lenses or monofocal plus lenses. So, here are the ones that are available in the USA. We only have three. We have the Vivity, we have the Symphony, and we have the Apthera. Now, obviously, we know the Vivity works by that central 2.2 millimeter element that changes the wave shaping. That causes a little bit loss of contrast, and it gives about a 1.5 diopter range. But remember, it's that central 2.2. So if you have a patient with a larger 4.5 millimeter pupil, only a quarter of the light's going through that central zone. Whereas if you have a patient with a smaller pupil, like 80% of the light's going through that central zone. This is also why we learned at the beginning, these patients end up with a myopic outcome. You aim for plano, they ended up minus 0.5, minus 0.75. So now with a small pupil in this lens, we aim for a little hyper in order to achieve plano. Because again, most of their central optical zone is taken up by this 2.2 millimeter focusing element. So this is really important. This will help you actually nail your target. You have to see for this lens, what's the pupil size. Now the Symphony is another good lens. That has rings in it, diffractive EDOF lenses, about the same 1.5 diopter range, but it's accomplished through diffractive rings. And all these rings here, it's not pupil dependent so much, because no matter what, you're getting light going through all of these rings here. And these ones, you can aim for plano to get plano. So with the Symphony lens, which has probably the worst dysphotopsias, however, I don't think you need to change anything depending on pupil size, including your refractive outcomes. And then the third lens that we have available is the Apthera IC8, which is a small aperture lens here, and it gives about the same 1.5 diopters of range. But of course, because it's a small aperture, you have loss of light. That's the side effect. So that central zone is actually only 1.36 millimeters on the IOL plane, and so we can do the math to see, well, how much light is transmitted to the eye, to the retina, depending on the pupil size. We can just do some simple geometry way back when we were kids, and you can see at a large pupil, you get most of the light going through, but if you have a patient with a 3 millimeter pupil to begin with this light, you may block out about 80% of the incoming light. So obviously, there's no way of cheating physics. So even if you love one lens over the other, always keep in mind the concept of the physics of it behind the lens. Now this lens, obviously, we talked about with a 4.5 millimeter pupil, you're going to lose about 40% of light. And these lenses, if you have a 3 millimeter pupil, you're going to lose about 80% of the light. And so in both these situations, though, however, you aim for a little bit of minus post-op. And the reason is you'll get a little bit more range, because obviously the pinhole effect, if your patient ends up minus 0.5, minus 0.75 with the pinhole, they're still able to see 6.6 at distance. So now let's talk about the IHANS. The IHANS is not, at least in the USA, not an EDOF lens. It does not meet the criteria. It's only a central 1 millimeter zone on an optic that's overall 6 millimeters and 5 millimeters of focusing. So because of that, it has a very modest effect. This is from J&J's own data. And you can see it's a very, very mild bump in purple there with the IHANS at 1 meter. Very mild, at a meter. That's not here, that's a meter. I can't reach a meter even. So keep this in mind, and you say, well, I have some patients who are so happy. Well, of course, with a 4.5 millimeter pupil and this 1 millimeter zone, only 5% of light goes to that central zone. That's not gonna have any effect. With a 2.5 millimeter pupil, better, now 16% of light goes to the central zone, plus you have the benefit of the smaller pupil giving you better depth of focus, depth of field. So here's another case. Look at the patient here. The IOLs in the eye, nicely centered up, sealing up the incision here. And if you look carefully, you'll see this is, again, an EDOF lens with a central focusing element there. This is that Vivity lens. I don't work for any of the companies anymore. Now my disclosure list only includes companies in which I have an ownership stake. And I don't own anything in B&L, Alcon, or J&J, so I don't work with any of them. But you can see here at the end of the case here, that's a beautiful centration, and that's obviously important as well, to line this lens up with the Purkinje images and, of course, the pupil as well. And these days we can do this with augmented reality with some of our fancier operating theater microscopes. And so I want you to keep this in mind when you're doing all this stuff. Think about pupil size. Someone asked me yesterday about a patient I talked about in Cataract Coach who is a +4 hyperope, and I put in monofocal IOLs in Plano OU, and they said, why didn't you do it trifocal? I said, I didn't need to. The patient naturally has, it was a woman of Indian origin here in Beverly Hills, has naturally small pupils, as you know. So with her 2-millimeter pupils, even with a monofocal lens, she had a fantastic range of vision because of this. So again, at the end of the day, I think one more parameter which we have to examine for all our patients is, what's pupil size? That actually is important. For us to deliver a truly refractive cataract surgical outcome, we have to take into account pupil size. And finally, again, for aiming your refractive target, for Vivity, remember, if it's a smaller pupil, aim for +0.5 so you don't end up myopic surprise. Apthera, I like to aim for a little bit of minus in all eyes because you have the benefit of the pinhole pupil. So that's kind of the summary here. We'll skip here to the very end, and then I will be happy to field a question, or we can move on.
Is there a pupillary size, say mesopic pupil of 2 millimeters, which sometimes extremely senile could be adult people could be having it, beyond which any of these multifocals or premium intraocular lenses don't work, and all of them work like a monofocal lens?
Right, that makes a lot of sense. If you have a lens that has concentric target, right, that has the diffractive rings, and the patient, even in nighttime, has a 2-millimeter pupil, you're not going to get the benefit of the multifocal. So I will not put a multifocal in someone who naturally has really small pupils, because they'll be thrilled with a monofocal. I'm not in the game of selling lenses. I'm in the game of giving the patient the refractive outcome that's going to make them happy, regardless of the lens selected.
So what about a EDOF like a monofocal plus or a VVT?
So a monofocal plus may be a benefit. With a 2-millimeter pupil, that central 1-millimeter bump may have even more benefit. Or a Vivity lens, again, be careful because that central zone of the Vivity is 2.2 millimeters, so they're going to end up a little myopic. They're going to see essentially only through that central zone. So just be careful on the targeting.
And just a last question. We are just getting the IC8 in the Indian market, and we don't have much experience with it. How's the uptake abroad, and where exactly we are all concerned about very little light going in, and
well, US FDA approval is only for the non-dominant eye, with the other eye getting a monofocal. That's the wording of the US approval. And that's how I use it too. I don't ever put it bilateral. I think that's a mistake. And so in that lens, just be careful. It also requires a bigger incision. And if you need to yag them, you have to yag a very special way outside of that central zone.
Thank you, Coach.
Okay, thank you.
So we have an old friend of India, Dr. Ronald Yeo, past president of APACRS, talking to us about fibrous anterior capsules.
Thank you very much, Dr. Ramamurthy. So I just finished my lecture on the other side on how to deliver a memorable lecture, and I forgot to add that you should never follow Uday Devgan when he's speaking. Okay, well, he's an impossible act to follow. But so I'm talking today just about fibrous anterior capsules. Now you know that there are capsules and there are capsules, and I think in India you see a lot of fibrous capsules. So with fibrous capsules, there are a few things you can do. If it's small and localized, you tear around. But where is it? If it's on the periphery, you're going to tear through it. They can be small, large, thick or thin, and they can be adherent, integrated, or they can be separate from the posterior, from the anterior capsule. And lastly, can you see it? So let's look at some movies, okay? So here you can see this fibrous plaque is fairly central. This is easy peasy. You start your rexis somewhere else, and you just tear around it, and the operation's over because the capsular plaque doesn't really come into play. It's not in the line of your capsulorhexis. So that's no problem. So let's look at another case now. Let's move on to the next one. What about when the fibrous tract runs across the CCC line that you're going to take? And you can see here, I'm going to aim for the thinnest part of the fibrous plaque and see if I can tear either through it or over it. And here you can see it's actually gone through that fibrous band quite easily, getting a good outcome. But you've got to be careful when you approach the fibrous band. Just be slow and steady. Now this is a rather more thicker, and you can see more opaque band, so it's likely to be more troublesome. Again, when I get there, I will re-grasp it just about now before I do it in my next pull and feel it. If I feel a lot of resistance, I will stop. But here I feel that it seems to be okay, so I carry on, and you can see that tears across the fibrous plaque together with the anterior capsule. So that's a nice outcome. It doesn't always happen like this, it's fair to say. Now in this case, again, I've raised the flap. You can see the two fibrous bands there. In this case, you can see that as I tear, the capsule actually comes freely over the two fibrous bands without involving the fibrous bands at all. And that's interesting, isn't it? Sometimes you tear over it, sometimes you tear through it. Now, what about this particular one? You can see this is a particularly nasty anterior fibrosis. So when I see something like this, you can see it's not so organized as the last one. I'm tearing through here, and I'm encountering resistance. What I said just now, you hold near the fibrous band, and you just test it, and it was too resistant for my liking, so I take out the venous scissors, cut it, and complete the capsulorhexis safely that way. But when you've got a localized area of dense fibrosis like this, you've got to be careful. And as I found out during the rest of the procedure, as I finished the phacoemulsification, there was an area of zonulysis, one quadrant of zonulysis in there, and I had some warning signs earlier, so a CTR is put in just to stabilize it. And the point really is when you see focal severe fibrosis like this, ask the patient whether they had trauma, a traumatic history, because forewarned is forearmed, and the patient had a good outcome at the end of the day. But you also got to beware the white cataract. As Forrest Gump once said, you never know what's inside a box of chocolates. You never know what's inside a white cataract. And if you look at this particular white cataract, this is quite an old clip, so the quality isn't fantastic. So I'm tearing around, and you can just about see the band that's just in front of my anterior capsular flap. And then here, you saw how that anterior capsule tore off because of the trypan blue, making your capsule more friable. And when you see that tearing happening, it means that there's enough resistance to pull. So I desisted in this case. I thought I'd come around from the other direction. I was being smart. Come around from the other direction to meet that area where I had resistance. And I thought it's only half a millimeter. Half a millimeter. I'm just going to tear through it. Whoops. Whoops. So that last half a millimeter is a pain in the proverbial, okay? So of course when this is done, you have to adopt really very slow motion phaco techniques to not make that anterior radial tear extend posteriorly. And the message from this, of course, is take your venous scissors out earlier rather than later. And finally, I do what I should have done at the very beginning, is get my venous out to snip that offending band. And at the end of the surgery, you see how thick that residual band is. No idea it was that bad when I started the surgery because it was a white cataract. Now here's another white cataract, okay? So what I typically do with these is, in case they're intumescent, I'll go in and just aspirate to decompress the intralenticular pressure, and then I start my capsulorhexis. And again, coming around here, watch for how your anterior capsular flap behaves. If it tears, it means there's significant resistance. And when I come here, you can see there's resistance. I confess, I didn't see the presence of that band. Can you all see that band? There's a V-shaped band there. I was so intent on looking at where I was tearing and where I'm going, I didn't see that band. And so I'm encountering resistance here, and I'm cutting where my flap is, not where that band was. So in here you can see I'm trying to snip it, and just to free that band which I thought was there, and you can see that radial, that circumferential snip I've put in there. And when I go and try and tear it, at some stage I finally realized that that wasn't the offending band, but it was the band that's right under my capsulorhexis forceps there. And you can see I'm picking at it. It's just not coming, just because it's still being held down by the band to the left of my forceps now. And eventually I realize it, and I'll take out the venous scissors to do what I needed to do really in the first place. So you really got to pay very close attention to these white cataracts, and you see that band there. I didn't see it. I only saw it at the end when I couldn't make progress, and then you just snip what you think is offending, and then the rest of the operation was much easier. Once that particular band was snipped off, I was able to catch that flap and continue with the rest of the rhexis as you see here. So just finally, my final video is, I think flex is quite a nice thing to do when you have a fibrous band. Now, so the question is, I've done the flex, has it cut through only the capsule, or has it cut through capsule and fibrous band? Don't know. Let's try. Pull the capsulorhexis, and you can see it's coming away quite nicely over the fibrous band. So you don't always need to go through the fibrous band. If the eye is kind to you, you can tear the capsule over the band, and you can see at the end of the surgery that original fibrous band is still intact. So just to sum up, fibrous capsules give you, sort of challenge you with your capsulorhexis. Beware of radial extensions. They can be occult. Beware of adjacent trauma or previous trauma and adjacent zonulisis. So just be slow and steady, watch for resistance, and observe its behavior. If in doubt, cut it out with your Venice. Thank you very much, everyone.
Thank you, Dr. Ron. While Dr. Aldave is getting ready, just a couple of quick questions. One is that I always find it better to stain these capsules, even if they are not white cataracts, because those areas become more evident and easier.
That's
And
a great point, Ramon.
And as you showed in the last video, I think having a femtosecond platform, just like in intusions and cataracts, is a great benefit here, because even though you may not get a free-floating rhexis, you get a nice template. And sometimes I raise the, lower the spot separation also, use higher energy, and especially in some of these thinner fibrous bands, it does cut through and you're able to complete your rhexis.
Yes, I've been impressed at how reliably the flax has cut through fibrous bands. It is good. Yes, I agree with your staining, because when I look back at the times I've stained the white cataracts, it's actually identified a number of fibrous bands and you can see them better, absolutely.
Right. Thank you. We can't ask for anyone better than Dr. Anthony Aldave to talk to us about cataract surgery in patients with corneal disorders.
Thank you for the invitation to participate. I'm going to speak from a corneal surgeon's perspective regarding cataract surgery and primarily screening your cataract surgery patients for corneal disorders. I have no relevant disclosures. This is part of a longer talk. You're fortunate this is the abridged version. I'm going to talk just about cataract surgery in the patients with epithelial basement membrane dystrophy and Saltzman's nodular degeneration. How common are these conditions? Well, obviously it varies depending on where you practice, but this article from a group in the United States reported in a series of patients, about 120 with cataract surgery, they identified epithelial basement membrane dystrophy in approximately 8% of the patients and Saltzman's nodules in about 2%. So EBMD actually is quite common. Saltzman's less common, but certainly you need to be able to recognize it and manage it if necessary before the cataract surgery, not at the time of. So this is a case of a 72-year-old gentleman who complained of progressive decrease in vision in his right eye. He had cataract surgery previously in the left eye. He had wore contact lenses for half a century, and he's told me that if he needed cataract surgery in the right eye, he was interested in a multifocal or a toric lens to optimize his uncorrected distance and near vision. You note on exam his vision is 20/70 with refraction. Exam, I'll show you a Sonam photograph on the next slide, shows negative staining in the central cornea, a 2+ nuclear sclerotic cataract. In the other eye, he had some peripheral epithelial irregularity that looked like epithelial basement membrane dystrophy and a toric lens well positioned. So this is the right eye. It's hard to see, but there's some lacy gray opacification here centrally that's actually much easier to see here with the fluorescein dye and cobalt blue illumination. So first thing I'd ask you, all of you, cataract surgeons, please always put in fluorescein, use cobalt blue illumination, and look for irregularity like this. You may already do this looking for dryness, etc., for PEK, but you should also be looking for epithelial irregularity. And this patient had what looked like a visually significant cataract. So topography, not surprisingly, showed a fair amount of irregularity with about 3.7 diopters of irregular astigmatism. The left eye, the eye with the toric, had 2.4 diopters of fairly symmetric with the rule astigmatism. So when do you treat epithelial basement membrane dystrophy? Well, when there's visually significant epithelial irregularity. I see on this case, definitely this is visually significant. If you have unreliable keratometry or topography secondary to the irregularity in a patient in whom you're planning cataract surgery. And also, how do you know in this patient if they're complaining of night vision problems, whether the complaint is due to lenticular opacification or the corneal irregularity? You don't know. So you need to treat the cornea first, and then if their problems persist, then proceed with a cataract surgery. And in patients in my practice with this condition, most commonly, they're symptomatic because of recurrent corneal erosions, more so than with epithelial irregularity. My preferred treatment is epithelial debridement and diamond burr polishing. Very easy to perform. You see here with a speculum in, this was because we have a minor procedure room right next to our clinic, so that's why I do the procedure. But many people will do this in their office at the slit lamp. It's quite easy to do. You remove the epithelium initially with a Wexel sponge. Even in patients without a history of recurrent erosions, if they have EBMD, the epithelium is usually fairly disadherent. I then use a 57 blade to remove any islands of adherent epithelium. Then I use this ophthalmic burr. It's about a 2.5 to 3.0 millimeter burr with very fine metallic flecks. In this case, what we're doing is, in essence, polishing Bowman layer. You want to remove the epithelial basement membrane. So debridement alone is not enough. You need to do this step as well. Once you do, then you place a bandaged contact lens. The whole procedure will take maybe 3 minutes. It's very easy to perform. Again, I don't think it should be solely the corneal specialist who does this. I think this is a procedure that's appropriate for general ophthalmologists to perform. So here's the patient following the procedure. You see a much more regular astigmatism here, 1.9 diopters. And the question is now, if the patient's vision improved a bit but still feel like they wants to have cataract surgery, what type of lens can you consider? Is it appropriate to consider a premium IOL in a patient with EBMD? Well, to make that decision, I think you need to go to literature. We've published several series on treating EBMD with diamond burr polishing. And in this case, we looked at the subset of patients with epithelial irregularity. At this time, it was 42 eyes. We're going to publish our new series, which is now up to about 100 eyes. None have had a recurrence. And this is now a follow-up of up to 20 years. This should tell you that this is not a dystrophy. This is a degeneration. If it were a dystrophy like other epithelial dystrophies, it would have recurred. It also means it is appropriate to put in premium channel lenses in patients if you treat them appropriately. All right, second condition, Saltzman's. I think you're all familiar with Saltzman's. We see here this isolated inferior nodule, probably from exposure. Here's a patient with prior LASIK surgery with nodules along the edge of the LASIK flap. But here's a patient who I saw last year on their pre-op evaluation for cataract surgery. That cornea looks clear, doesn't it? You may say, well, hard to tell, there's a reflection of the lid up here, so I can't see. Well, if you lift the lid up, this is the reflection of the Q-tip, you don't see anything with this illumination. Again, besides using cobalt blue illumination and fluorescein dye, please also use tangential illumination in all your cataract surgery pre-op evals. Same eye, but now with light coming at an angle, we can see the subepithelial fibrosis. You'd say, well, okay, you see some of that, but what does that matter? Well, that triggers you to do a topography, and look how much flattening you have, 4.3 diopters. You definitely want to recognize this and treat it before cataract surgery than trying to figure out why the patient doesn't see well after cataract surgery. So here we are following a keratectomy, and you notice now a significant irregularity of that cornea. The average K value here, 43.56. Again, prior to the treatment, 41.5. So you have a over 2 diopter steepening following removal of the subepithelial fibrosis. Again, you want to do that before your cataract surgery rather than after, because afterwards they're obviously not going to be happy with the lens power you put in. So what are the indications for treating Saltzman's? Decreased vision secondary to direct obstruction of the visual axis or induced irregular astigmatism, unreliable keratometry or topography secondary to the induced irregular astigmatism, and to differentiate between vision loss between the cataract and the Saltzman's. I would implore you to do topography or tomography in all patients with any Saltzman's nodule, no matter how small it is or where it's located. You never know how much astigmatism it's inducing. The question is it appropriate to put in a toric in a patient who had Saltzman's nodule that you removed? Well, if you look in the literature, this paper looked at several different series of Saltzman's, and they reported follow-up range here of about up to 2 years, and recurrence rates anywhere from 0 to 31%. So what this means is Saltzman's nodules recur not uncommonly. They're due to a number of different conditions, of course, and many of these conditions will cause recurrence of the Saltzman's nodules. So I would say, given the fact that Saltzman's nodules commonly recur, you should not be putting in torics in patients with Saltzman's nodules. All right. Now, what happens if you miss these conditions and you treat them after cataract surgery? Well, this is a paper from the group at Duke, and they noted in patients with EBMD that following treatment, they saw an increase in the average K value of about 2/3 of a diopter, which changed the IOL power, if you're targeting metropia, by almost a little over 3/4 of a diopter. If you're treating Saltzman's nodules and you treat them after the surgery rather than before, you're going to be off by about 1.4 diopters as far as the targeted IOL power. So, in conclusion, topography should always be performed prior to cataract surgery in anybody with EBMD involving the central 5 to 6 millimeters of the cornea. If they only have very peripheral map lines, it's not going to affect their vision. You don't need to do topography. But anything in the central cornea, you should. Any Saltzman's nodule anywhere, though, you should do topography. If you do see visually significant irregularity, you need to do the treatment before cataract surgery, not at the same time. A toric or multifocal IOL, I believe, is appropriate to implant following successful treatment of EBMD, but should not be implanted in patients with a history of Saltzman's. Thank you very much.
Thank you. Can I take a question? You covered these two aspects quite well. Another corneal condition we frequently come across is Fuchs dystrophy. Initially, we used to have a guideline that the cornea thicker than 600 microns, endothelial cell count less than 600, go ahead and combine it with a DSEC or a DMEC. But nowadays, at least in my practice, we always do if the cornea is clear, go ahead with the cataract surgery and address the endothelium if it decompensates. What's your thoughts on this?
It's a good question, and this could be like a discussion for 20 minutes, which we don't have. You know, using just central corneal thickness should be taken into consideration, but obviously there's a lot of difference in the population regarding what is their baseline thickness. So what I say is anytime you have a Fuchs patient, try to get a pachymetry early on when they're young so you know what their baseline is. And I'd say any increase of more than maybe 60 to 80 microns, even if it's only 600 microns at that point, should trigger you to think about doing a combined procedure. The other thing I'd say keep in mind is if you have a Pentacam device, Sanjay Patel has taught us a lot about looking for subclinical edema on Pentacam. There's a few different parameters you can look at, and in my practice, if I see evidence of subclinical edema on the Pentacam imaging, I will typically go ahead with a combined procedure, even if I don't see stromal edema on exam.
Thank you. Thank you.
Thank you.
Next, we have Dr. Miguel Marcelo, who's going to be talking to us about myopia and presbyopia, current surgical options.
Thank you very much for the nice invitation. I'm going to talk about the current options that we can offer to our patients that come to the refractive office looking for solutions of their myopia and presbyopia problem. These are my financial disclosures. As a refractive surgeon, I think these are probably the most the most difficult patients to please because as we know that myopia is good for presbyopia, and many of your patients, I'm sure, they remove the glasses, they use the myopia for reading and near activities. So we can consider that people that ranges myopia from 1 to 150, they start to use readers late in the presbyopia, maybe a 50, 55-year-old. People that ranges 2 to 4 diopters will always enjoy an excellent near vision. And people that it's higher numbers of myopia, well, in spite they enjoy very close near vision, but it's true that this is not as functional as the previous situations. So these situations, I think, should be explained very clearly to these patients that all of them are going to lose this fantastic near vision they enjoy, but they will change into a new refractive range of vision. And we have to give the realistic expectations. Myopia and refractive lens exchange is something very, very controversial and very careful to perform. It's not the choice procedure because we know all the higher incidence of risk of developing a retinal detachment is clearly described in the literature. Although I found this retinal detachment risk calculator online that points out like the main factors of retinal detachment risk, not having still developed the posterior vitreal detachment, and the presence of lattice degeneration in the periphery. Another problem that face here, of course, the potential surgical damage, the difficult IO calculation, especially if those patients did LASIK before, the complete loss of the accommodation, and especially difficult in early presbyopic, and they are less likely to end with 20/20 vision with uncorrected visual acuity. And of course, the irreversibility. If the patients are not happy, we cannot give back. Of course, this is a totally acceptable procedure if the patient is developing cataract. The classical monovision, I think this is still a good choice for many of these patients, although, of course, loses efficiency with time. We rely on the standing still accommodation that we know is going to be lost in time. The results of the monovision are different based on the different age of the patients, the best corrected visual acuity, the degree of binocularity. It's very important to find the dominant and non-dominant eye, and in my case, I am very frequently using a contact lens trial before, especially in those cases that are a little bit doubtful. The performance of the monovision in the myopia, it's quite good in most of the patients, although when you perform with laser procedures, is frequent slightly highest enhancement rate, because especially for the eye for far, the eye for far should be very close to the metropia. They are very demanding in this case. There is some percentage of reversion of this procedure. Some people at the end, they don't like it, and we have to go for the full correction. And it's possible they may use some spectacles for driving. And then in some conditions of long time near activities or low light conditions, they may use also readers. I think this procedure is better for easygoing patients. Less suitable candidates is people that is, in generally speaking, very demanding with the precision of the activities. That is why, in my suggestion, is most of the cases, if you don't find the patient very confident, do the contact lens trial. Another alternative, which I am not expert on this, is the Presbyon procedure provided by Zeiss. Suppose that it's enhancing it's like a monovision with enhanced range of vision due to this non-linear ablation that provides an extended depth of focus. Although the results I've seen in the papers are variable, and I found a paper which the results were not very good, or at least not so excellent as they provide. Another procedure we can offer is the presbyopic IPCL, which is a lens that I am using for the last 2 years when it got approved in UAE. It's a phakic refractive IOL inserted to a 2.8 millimeter incision and has currently the widest range of the market for corrections. The folding of the lens is very easy with an injector. The only thing we have to be careful not to trap the lens and put in a upside down position. And during the injection, we have to make like a 2 times injection, injecting the first half of the lens, waiting the lens to spread, sometimes get stuck, but it's very easy to implant like any other phakic IOL. Regarding the addition that we can choose for our patients, there are some tables that come, they consider the age of the patient we are implanting. Of course, they are advising the younger the patient, the less addition. Although in my small experience, I think that we have to go for the highest possible and tolerable, especially for the dominant eye, addition. Because maybe the lens is working for early ages, but with time the remaining accommodation will be lost, and then they have to rely only on the addition that we have chosen. So maybe the highest the addition, the better. The presbyopic IPCL is indicated in people with thin or suspicious cornea, with high myopia, even with a mild amblyopia can still be used. People that is demanding for very good near vision, we can add high magnification. And people that are not happy also with the contact lens trial we did for monovision, they demand more vision. And in this case, we avoid the retinal risk because we are not removing the lens. According to the published results, these lenses provide very fast recovery. There is no need for IOL calculations that we can maybe face when we do a refractive lens exchange in pre or LASIK patients. The volt is quite stable with time. More than 1 week, the volt remains the same. It's exceptional if you choose a very good addition, the use of reading glasses. And the reported AIOS or glare, in my experience, they are not very very high, and of course, if they have, you have the possibility of reversing the procedure. And with a very good technique, the endothelial loss is minimal. So to finalize, I would suggest this decision tree to deal with these patients. I think especially for people that has not developed very high presbyopia in early ages, to go and try the monovision, to offer the monovision, do a contactless trial. If the patient is happy and the laser procedure is suitable, then go for a laser procedure with monovision. If it's not possible, or because of the cornea has some problems, or the patient don't like the result, then we can offer the IPCL. If the IPCL is not the presbyopia IPCL, if the IPCL is not suitable, then we can see the retinal risk of the patient and consider with the patient the possibility of a refractive lens exchange. But if not, all these things are not possible, of course, then we always have to rely on try the contact lens and the monovision and leave the patient as it is. Thank you very much.
Thank you for that comprehensive overview. That was a nice overview. I have also got some experience with this presbyopic IPCLs. The challenge is what power to put in, because it's a progressive condition. Patients are there right from 40 to 60. Usually I put a plus 2.5 and a plus 3, plus 2.5 in the dominant eye and plus 3 in the non-dominant eye. And that seems to serve the patient even in their later years. Would you agree with that?
Yes, absolutely. I will not go for lower powers because, number one, you are dealing with patients that they have an excellent near vision. And then, of course, you have to tell your near vision will not be as good as you enjoy now, but it could be acceptable. But if you let's say, put a little bit more, you will be always on the safe side. So this is a good start. A good start.
Good. And I think the EDOF ICLs are also coming up now.
They are saying that the fact is that they told me about them 2 years ago, still delaying. I am curious to see.
It's available now in India.
Very good.
Thank you. Next we have Dr. Jodh Mehta from Singapore talking to us about reducing dysphotopsia, another frequent visitor to Indian meetings.
Thanks. Great. So thank you for the invitation to talk in this session. So I'm going to be talking about reducing dysphotopsias. These are my disclosures, really plain to Telion at the top right over there. So as you've heard from the previous speakers, the evolution of cataract surgery has led us to a situation really where cataract surgery now is really a refractive procedure as a purely therapeutic procedure itself. And really, dysphotopsias are the most common cause of basically complications following routine cataract surgery. And this can occur with any of the conventional posterior chamber IOLs that we currently use in the market. You can classify them as positive and negative, and you can see from the pictures above on basically how these will occur to basically the patients as well. And it's important to really get a good history from the patients on the details of the surgery if you can, if you did the surgery yourself, or if they've had it done elsewhere, the patient's symptoms, the focus on the onset, the location in the visual fields, and some of the alleviating factors and how it's affecting their quality of vision when you're basically seeing the patients as well. Reassurance and validation is important, especially for negative dysphotopsia, because often this is excluded by many surgeons and dismissed with respect to causing any visual problems because their central vision is quite good. And of course, if you can look for obvious pseudofocal adhesions by looking at the fourth Purkinje image, this will give you some idea of the lens. So if we look at these individually, positive dysphotopsia, most of you will be more aware of. Of course, you get this from a lot of the diffractive multifocal lenses, this unwanted lighting or flickering of the lens itself. And it, of course, comes from the obliquely rays coming across the edge of the lens itself. And this has been reduced by some of the technologies with respect to the edge profiles of some of the lens as well. It's important to basically treat any of the ocular surface disease if it's associated. This can significantly improve the symptoms of the patients. So I'll just show you an example of a patient that sent to me, an 68-year-old lady, Chinese lady, bilateral cataracts, normal fundal examination, had routine cataract surgery with a pretty good visual acuity outcome. At 1 month post-op, she noticed a streak of light around the individual light zone. And you can see unaided vision, not too bad. Best corrected vision, very good. The streak was still presented with basically full correction and no difference with scotopic or mesopic condition. And she was told to basically wait. 3 months later, she came back to the same doctor, same issues as basically complained beforehand. This is what the eye basically looked like. And they were sent to me because they thought that she had some induced aberrations on the cornea and thought this may be causing the problem. So they thought that we could sort out this by doing some laser treatment. So at 4 months post-op, when I saw her in clinic, in fact, this is basically what she looked like. So the aberrations actually were completely fine, basically, in both eyes, both on a tomography and also with respect to a spherical aberration itself. So clearly, she's getting basically a streak light phenomenon from that basically lens itself. So the options were either to do basically a lens exchange or basically just do a YAG. So I thought, okay, well, you know, obviously if you do a YAG first, and then obviously the fold is on there's a mark on the lens, it's going to make your lens exchange slightly more difficult. So I thought, let's have a look at basically the capsule in a little bit more detail. And when I took it to OT, actually it was quite simple to basically see what was going on here, because basically once I started to shift the lens across from side to side, you'll see actually the crease itself basically just starts to disappear. So I started to lift the lens up, and then when I moved it a little bit, you see the crease basically just goes anyway. So this is basically a fold in the capsule, which I couldn't actually see on the OCT basically pre-operatively. So when I shifted the lens around, I was able to shift the flow out to basically one side, and I thought, okay, this will probably help alleviate her basically central symptoms. And of course, the reason why this happens is because very few of us actually even measure the capsular bag when we're doing our cataract surgery. And if you put the lens inside the bag itself, of course, larger bags, the smaller bags, it's going to have an effect on basically how you can basically get these creases. So, of course, the crease basically had moved to basically one side. She had better repositioning of her symptoms. And now, basically, she told me she only gets this at nighttime, and she was happier, basically, with her visual acuity result. And, of course, now she was keen for cataract surgery on the other side. So what are we going to do in that side? So I decided to choose a lens where I could basically exclude the whole issue of the bag sides. And, of course, we YAG basically the left eye. So the lens I basically use is the Femtis lens, and the Femtis is a lens that basically clips to the anterior capsule of the eye itself. So normally the cataract surgery has to be done by flax in the situation. So normally the Z8 is basically programmed to have 2 extra ports on either side to allow me to do the manipulation after I basically do the surgery. The rhexis with the lens is about a 5mm rhexis. Then following the cataract extraction, you basically will see the lens will basically inject it inside the bag. It comes in the injector. The Telon injector is slightly different. Normally you have to check the lens to see the anterior flanges are basically correct on the anterior surface. Of course, this is going to clip to the anterior capsule, so it's worthwhile checking before you input the eye. There's different platforms available. This comes on a monofocal and also an EDOF platform, and also a refractive trifocal platform as well. So once the lens is basically injected inside the anterior capsule, you remove all the viscoelastic basically from behind the lens itself. And then what I do is I inject a little bit of viscoelastic basically onto the surface, and then using the extra ports basically on the side that you've created with the femtosecond laser, you can basically then anterior enclave those little haptics basically onto the surface. There are 4 haptics, 2 large ones, basically 2 small ones. The viscoelastic is now going in on surface, and then I just go in with a Sinskey hook and just gently manipulate those anterior those flanges onto the capsule. The other advantage is, of course, if you're putting a toric lens in the situation, when you actually fixate it into position, it will be absolutely stayed in position itself, because it will remain in the actual position on the surface as well. So you just put the 2 ones on the side. Okay, so this is basically how she ended up on the right eye, day 1, YAG'd on the left eye itself, and you'll see on the UBM basically how she's positioning of the lens on the anterior capsule, basically on the UBM eye, and basically the ones in the bag basically in the other eye, and of course the other advantage, you can reduce the astigmatism with this lens. So let's see the opposite case, a negative dysphotopsia. This is a Singapore Airlines pilot who had cataract surgery done by a colleague of mine, routine surgery, good visual acuity outcome, but was complaining of basically a shadowing basically on the left side of his vision. So she YAG'd him because she thought it may actually get better, and then after a year she sent him to see me to basically have a look. So this is negative dysphotopsia, and of course this occurs basically relating to this blank in the gap in the field of vision, and often you see this with the kind of edge effect of basically the lens itself, but it does improve to time, between 15 to 3% over basically 1 year. So again, he underwent, on this side, what I did was I did a reverse basically optic capture for him, because when we did a UBM, I could see there was a partial shift in the lens, and this is quite well treated if you can with a plate, with these haptics, with a reverse optic capture. You can rotate the lens, so it's in a 3 and 9 o'clock position to reduce the symptoms of this as well. And of course, if that doesn't work, you can always basically do an IOL exchange and a piggyback. So following his reverse optic capture, he was happy with the visual acuity result. He said the symptoms are only basically on his extreme side. And for the other eye, obviously we had a choice of either doing basically a femtis or putting a reverse optic capture to a primary procedure. So again, the surgery is the same as I've basically shown you previously. So the lens will go basically inside. So after basically clipping, I'll skip the video, which is in the interest of time, just to show you the clipping itself. So once the lens is in the bag, you can just basically adjust the haptics so they basically clip into position. And normally I give some Myocol to bring basically the pupil down at the end of surgery to just make sure the lens position and the flanges are nicely lying basically on top of the capsule as well. So, you know, he told me the surgery in this eye was basically completely different to what he basically experienced on the other eye. So with this lens basically comes in different formats. So this is the one that I basically use. I use the Femtis Comfort, so it's a refractive lens itself, so they will get distance and intermediate in there, and I often do a mismatch between the two lenses that will give them distance and intermediate and also basically in their mission, but it's affecting the ELP position of the lens that will allow you to get very accurate basically outcomes. This is a very nice little algorithm that was basically published, I think, at the end of last year, which shows you how to manage these patients with negative and positive dysphotopsia as well, and it gives you an idea to basically look at the timeline for basically these patients as well. And we don't see many of these cases, luckily, but I think it's worthwhile acknowledging them when you basically see them. So in summary, dysphotopsia is the most common complication after routine cataract surgery, and it can occur with basically any current posterior chamber intraocular lens technology. Clipping of the lens to the anterior capsule can avoid this problem with respect to negative dysphotopsia, and enhanced refractive optics of this lens basically will reduce the symptoms of positive dysphotopsia itself, independent of any capsulotomy variation, which is improved because you get accurate, effective lens position. Thank you for your attention.
Thank you, Dr. Jyot. We also have something called the negative dysphotopsia ring available to us.
That's right. Yeah, I saw. Yeah.
Yeah,
I haven't used. I mean, that's a piggyback, right? You're putting it on
That's
top
right.
of the lens as well. And I saw some trials. I think it comes from
the CAG.
not Sam Mascot. It works with Nicole Fram, and it basically goes and crop on the surface itself
And covers the optic
covers the optic. I
square
think that's
edge.
very useful if the lens. So if you have a plate haptic lens inside the bag, then I think that's a great option, right? But I think that, you know, you can, the ones I've done basically, and doing the retro reverse optic capture actually works pretty well. People have been quite happy with that. And I've been doing that as well.
And if the
seems to go
margin is visible, doing the YAG is the simplest option, I think.
for the, in the,
If the rexus overlap on the
yeah,
nasal side
if
is
you
visible.
can see it, yeah, if you can see the thing.
Thank you. Next we have Dr. Anand talking to us about phakic IOL in low and
Good morning. Thank you, AIOS, for including in this session. My topic is my clinical experience with the Volax enhanced monofocal visions. So, what is a monofocal plus or enhanced monovision? It's basically the optics of the monofocal lens, which give a distance as good as a monofocal, and it gives some kind of functional near vision or intermediate visions. That lens is called, and this is probably the next half decade that will be the lens of the choice. So the meeting of the visual needs, because every company, every IOL manufacturer is going towards that, because the need of the patient is become increasing over the light. Even the aged patient uses a lot of time over the laptop or driving and a phone or my mobile phone, and say need to have some kind of intermediate vision, so which the standard monofocals are unable to give. So if you go for the basics of the optics of the lens, there is apart from the diffractive one, there is three kind of lenses now. It's available: spheric, aspheric, and aberrated. And when the spherical aberration and aspheric is mixture, there is some kind of aberration which creates it's slightly aberrated optics, and which can able to give you some kind of elongated focus. So going to the basics of the lens, if we have a negative positive dysphotopsia, positive asphericity in the cornea, which is negated by the lens, is having a negative negative asphericity, which actually if we put a normal neutral or positive aspheric lens, the focus, that some rays will be in front of the retina, all rays will not able to focus in the retina. So if we go for the spherical and aspherical lens, the difference is every point of the spherical lens, if you consider the 20 diopter, every point is actually a 20 diopter. And the peripheral lens, once the incidence of ray is different, some rays from the periphery is actually focused in front of the retina. But what is aspheric? Aspheric actually, according to make a sharp focus, they may actually actually the change of the power of the periphery. If it is a 20 in the center, it is a 9.1 is the periphery. So it is able to, this is a beauty of the aspheric lens, and this is a quite some time this is a standard practice. And these are the all lens, all EMB lens are actually mixing these sphericity and asphericity in the central part of the region, central part, and they are able to give some elongated focus. That there is a long debate of the which lens is called a enhanced monovision or which is called EDOF lens and extended depth of focus. So it's by my understanding EDOF lenses, which lens is constantly give the intermediate vision, which we called EDOF lenses. So far we consider Symphony and the Attila, all are the diffractive design lenses are considered as the EDOF lenses so far. And the other part, which is the IHANS and the other lenses which consider EMB lenses, enhanced monovision, that means it gives a, these are not the constant for give the intermediate vision. What Evolux is inducted, this is a EMB lens and the extended depth of focus, and Evolux is a hydrophobic platform, and it is an innovative design, and the center 4 millimeter, as I said, there is a opposite sign spherical aberration, that is a combination of the positive asphericity and the negative asphericity. They are able to create some kind of elongated focus, and some able to, the patient can able to see at that range of the 60 centimeter. If you see that the focus, this is a single focus point, and that the Evolux is able to create a so design, and they gave a elongated single focus area and far to intermediate. And see, this is the beauty of the lens. And if you see the MTF curve of the lens, there is a distribution of the energy. There is a distribution, there is a high spike in the plus 1.5, so it gives a intermediate vision very well. And these lens are all the EMB lens. If the zone is very small, these lenses are basically a combination spherical asphericity and spherical and negative asphericity in the central part, so that the zone of the area is very important. As it has a 4.5 millimeter, it can able to give a good quality vision up to 3 millimeter pupil. And you see, if it is the pupil size is 4.5, the intermediate vision is dropped down. And other the lens which is available in the market, they have even smaller zone. That's why that the pupil size of the patient of these other brand is very important. Even they're not able to give a very good vision, intermediate vision in the 3 millimeter zone. This, if you get this point spread function and everything, it is 99% fall in the within the spot of the 20 millimeter, 20 micron, and similarly the almost standard monofocal IOL, but there is some kind of diffraction from if you give the standard monofocal vision, but it will not keep any hamper your driving and other day-to-day activity. You can see the defocus curve. Sorry for the small slide. It is a very good compared to other vision. It is Evolux giving a 1.5 minus 1.5. It is a give almost logma table 0.2. So it can give a better intermediate vision and almost like any kind of EDOF lenses. As a monofocal IOL, Evolux designed to have good tolerance to unexpected residual refractive error also, as the zone are slightly bigger. You could compare to the monofocal to Evolux, you can see the optical chart, and you can see the refractive error. It almost similar to the any kind of monofocal vision, monofocal IOL. And it is a hydrophobic material, made of hydrophobic material and non-glistening type. It don't have a glistening, which as other company has. So Evolex is almost monofocal plus oil manufactured by SIFI and hydrophobic preloaded version. It works a spherical aberration concept, as I said, and combination of positive asphericity and negative asphericity at the 4.5 millimeter. It's a bigger one, and it gives a excellent intermediate vision. So my total implantation, I have so far implanted 143 and bilateral implantation 27, and I am very happy. As company said, it is almost give as good as it's a really good, it's give a very good result at the 60 centimeter, and it needs only 1.5 most the cases for the near 30 centimeter. And I mix and match. I implanted first eye, 29 cases first eye hands, and second eye I implanted Evolex, and there is a lot of difference for the intermediate from eye hands to Evolex. Evolex is a much better way to give the intermediate vision. And if you consider EDOF, it is actually, if Evolex is very close to EDOF lenses. Thank you so much. Thank you for your patience here.
Thank you, Arup. We know the optics are quite different, the VVT, the eye hands, the Evolex, etc. Very shortly, how does the performance of this lens differ from the others? I'm not talking about the
these all the lenses, starting from eye hands, Evolex, and all the EMB lenses, not 100% consistent. There's sometimes you need you need the patient need 1.5 for near. Sometimes you need 1.75. Sometimes need 2. But compared to other diffractive video of IOLs like Symphony, it's a constantly give intermediate vision. So far, if you consider the 3 lenses, eye hands, VVT, and I think VVT and Evolex give a very close. But yes, Evolex price is much less than the VVT. And eye hands, yes, it's a path-breaking technology. It came 2 years back. We already experienced the eye hands. We can understand that the eye hands is a very good lens, but it is not consistent always.
Speaking to us.
Thank you. Thank you very much for this opportunity. We are going to look a little bit more on higher order aberrations. I'm from South Africa in Cape Town, and thank you very much for being here. So I don't have any financial disclosures. There was a lot being said already about higher order aberrations in this session, so we're not going to look a lot into detail. We are going to mostly focus on spherical aberration and also on coma, and importantly, how this can help us with decision making. Firstly, how to decide, or how to help us to decide when to do surgery. We are going to look more into spherical aberration on coma, and also how it can help us to not to do surgery. Okay, so this is a patient that I saw recently, 58-year-old. He complained of deterioration of his vision for the past 2 years. He was seen by another ophthalmologist and was told that his spectacles were just wrong. His vision was still unaided 20/20 for distance, but you can clearly see here on the tracy higher order aberrations internally. He had a high amount of coma and also spherical aberrations coming from the lens. So I will offer cataract surgery for him. And this is important. So the accurate assessment of visual function interference by the lens opacities can help us to choose the best time to perform cataract surgery. We know that in early stages of cataract formation, patients may suffer from decreased visual quality, whereas visual acuity in standard conditions is still preserved. As the nuclear lens density increases, the spherical aberration in the internal optics of the eye shows a negative shift, increase in negative spherical aberration. And cortical cataract shows more amount of coma and also trefoil. So now we're going to look at spherical aberration and specifically how it helps us with intraocular lens choices. This patient was a 55-year-old female. She had previous radial keratotomies, and she was used to monovision contact lenses using the non-dominant eye, the left eye, for near vision. She was happy with the quality of vision that she had before developing cataract surgery. Note the high amount of higher order aberrations on the right eye, especially that was a dominant eye, and also a high amount of spherical aberration in this eye. So on the right eye, I've inserted aberration correcting intraocular lens of 0.2, and this helped to decrease the amount of spherical aberration on your right eye for good distance vision. On the left eye, she didn't have that much amount of spherical aberration on the cornea, so I implanted a ray 1 EMV that actually increased the positive spherical aberration, but that gave you a good near vision. And this was now already been spoken of today about the normal corneal sphericity of that is 0.28, but to note that it is usually increased in myopic corneal ablations and usually decreased in hyperopic corneal ablations. And it is possible to counteract it with the opposite type of intraocular lens. But just to note that neutralizing the spherical aberration can give us better contrast sensitivity, and it can give us a best distance acuity, but it can also reduce the depth of focus, and by inducing spherical aberration can improve the intermediate vision, and that was also spoken of today already. It is good practice to keep it less than 0.6 micrometers, otherwise it goes into the toxic range. And this is exactly what was also being said, that the ray 1 EMV uses mostly positive spherical aberration. Most of the other type of EDOF and also enhanced monofocal lenses uses negative spherical aberration. Some uses a combination of the two. But it is also important to note that if you have loose zonules or if you have a decentered ablation, it is safer to stay with a spherical or aberration neutral intraocular lens, especially if the decentration is more than 0.5 or 0.6 millimeters, because then you can get quite a decrease of the MTF. Now we're going to look at coma, and I'm going to explain it with this patient. This is a patient that had previous LASIK. He had complicated LASIK in his left eye with quite a high amount of irregular astigmatism, but on his subjective he also corrected to 20/20 on both eyes for distance still. He had quite a high amount of astigmatism also on subjective. So you can see here that his topography shows this irregular astigmatism, high amount of high order aberration, spherical and coma on the right eye, and even on the left eye also it looked worse, with a higher order aberrations of almost 2 micrometers, spherical of 0.6 and coma of minus 1.57. So now is the question, what type of toric intraocular lens to implant, and we try to correlate the amount of astigmatism from the different devices, also with the tracy and the subjective refraction amount of astigmatism. So implanted a toric intraocular lens, but the aberration neutral type of lens in both eyes. On the left eye, he had a refractive surprise of +2, although on the auto-refraction it showed still remaining a cylinder of -1. He corrected with a +2 only and did a piggyback for him on this eye. The right eye, he had a very good result with a low amount of astigmatism that was left. And also note that at 6 weeks he had quite a good, this was only monocular or monofocal lenses that was implanted, and he had a good functional near vision of N5 binocularly. And this is important to note that when we look at coma, the manifest refractive cylinder can be influenced by the perception of coma as astigmatism. So a cylindrical lens can provide some visual benefit and is accepted by the patient as a partial correction of the coma. So toric intraocular lens calculation, in a high amount of coma, it is important to look at the subjective refraction to guide the amount of astigmatism to treat. Also, this is shown in this graph that if you have a normal cornea, yes, then you can go straight to your K readings, but if you have a high coma-like high order aberrations on the cornea, then it is needed to also look at the subjective refraction. And also to note that coma can also simulate accommodation, and specifically the vertical distribution of corneal refractive power with the greater refraction located in the lower part is most relevant to apparent accommodation. Now, just lastly, when not to do surgery. So this is a patient. He was a 59-year-old. He was a stargazer, and he had previous LASIK. So you can see here that the internal high order aberrations was actually more than the total high eye aberrations. And this we can sometimes see that the total eye coma can be counteracted by the corneal coma. And after LASIK, so he had LASIK many years ago, this increase in corneal aberrations can be negated by the lenticular increase in aberrations. And this balance between the cornea and the internal aberrations and the neuroadaptation, of course, can be disrupted then when doing lenticular surgery. So be very aware, especially in early cataracts with aberrated corneas. So then just in summary, it is very important to look at different factors. It's very important to look at the aberrations coming from the cornea and from the lens, whether you want to induce it or whether you want to use it. The pupil size have also been shown today that it is very important and remains an important factor, and all of this needs to be considered to give us a good modulation transfer function and ultimately a happy patient. Thank you.
Thank you. Would you ever consider doing a topo-guided PRK to regularize the cornea before taking up the patient for cataract?
Yes, no, of course. That patient specifically, because he was quite traumatized from his previous LASIK, and he told me he doesn't want corneal surgery at all. So he wasn't motivated, but he was counseled that it's a high possibility also after surgery. So I think overall I tried to get away with as least possible. And it's amazing sometimes with the neuroadaptation how much patient can sometimes tolerate, sometimes not. But sometimes you're lucky and then you can at least just do one procedure. But definitely that's a consideration.
Thank you so much. And that brings us to the end of our session. Thanks to all the speakers for this wonderful insights. And thank my co-moderator, Dr. Ayan Mohanta, for joining here. Thank you all for joining us.